there's probably enough of us for me to get going. I'm going to take a nod from Louise and Hannah. And just to say, there's very much a context to all of this, and to let you know that we recognize that there's a lot here. I don't mean for you to read every single word on the screen, but just be rest assured, this isn't a sort of session where you're going to hear, you should do this, you should do that, you should do this, you should do that, and by the way, it all costs a lot of money. We're very aware that these cuts, for those of you who are coming to us from local councils, and I recognize a few of the names because we've worked with a few of you over the last few years that we've been working with Cheshire and Merseyside, that we're very aware of the cuts that have happened in local councils, and also the NHS, the cuts that they've had to deal with in the last year. And just it's not just the number of, you know, the budgets and the money, it's also the people. I'm very aware, working with some systems, that, you know, people are saying, I'm doing the job that 3 people did last year. And I know that that's also happening in the NHS. So it's the funding and what services are available, but it's also the pressure that I think staff are under themselves, and the morale issues around morale. Next slide, please. So with that proviso in place, just to say, this is why we're here. We're here because some of you might know, hopefully quite a few of you, that we at the Institute of Health Equity were asked by CHAMPS to come in and help with their health inequalities approach. We've been asked by a few systems to do this, and this happened in the middle of the COVID pandemic. And we just finished our work in Greater Manchester. So Cheshire Merseyside was really our 3rd place. We'd already worked in Coventry. And after working with the system and identifying what was going on, what was working well, what could be better, we launched our report in, gosh, it's almost 2 years ago now. So the first session we had, we had probably, I think, close to when we launched it, not the final report, but when we launched it, I think we had about 600 or 700 people. It was huge, a huge first meeting that we had. And then we held a series of workshops as well. And then the final report was launched in May 22. And we also had a nice piece that appeared on BBC Newsnight about poverty. And if I can remember rightly, I think they went to Crewe to film some of that. So some national attention there, which I would say the system is pretty good at. I know I saw that Liverpool public health team had some good attention to their recent report last week. So, you know, we had some good coverage from our point of view on the issues that we raised in the Cheshire Merseyside report. And what we talked about is we go through all of our key themes, and we talked about taking a social determinants of health approach. And we talked about the drivers of health equity. What do all of these things mean? Some of you may know this, some of you may think you know it, and some of you know it really well. So let's move on and talk about some of these definitions so you can understand what's in that report. Now, there's a bit of a difference here between understanding what equality means and understanding what equity means. And I used to be one of those people who thought, it doesn't really make a difference as long as we all kind of get the sense that it's unjust, it's avoidable. But actually there is a difference, you know, and it is important to talk about it. And this is a really nice graphic that the Robert Wood Johnson Foundation in the States sort of first came up with to describe, and there's variations of this, but this is one of the original ones that they put out a few years ago. And I think it illustrates really well that we don't mean, look, everybody has a right to have good health services. Yes, that's right. And that's what equality is. Everyone's getting a universal service, and isn't that great? But the reality is, and for many of you working with the public or working in the NHS, you know that even when you offer that universal service, some people are going to be first in line, knocking on the door, asking for that. And then other people, in a way, regardless of how many times you offer it to them, may not come. And they probably need your services, but they're not coming. So it's about adapting that service. So in this instance, it's not just giving everyone a bike and saying, why don't you just cycle more? It's about saying, okay, well, let me find a way to ameliorate or amend my services or my offer to make it suit you as well as suit us. So if we want everyone to cycle, we just have to accept that maybe we offer a slightly different offer or we make our offer slightly different depending on the needs of people. So it is about understanding need and overcoming those. You might call it barriers. I wouldn't necessarily call it barriers, but overcoming the specific needs of each of these groups. So I think it's important for us when we get talking over the next couple of hours to think about, are we just talking about offering a better universal service, or is it really about thinking about, well, how can we make our services a little bit more responsive to need? Next slide, please. So equity, equality, tick, we've done that. And now it's social determinants. We talk a lot about the social determinants of health, because what we know from various pieces of research, and we'll talk about that today, is that it's estimated about 80% of your health is based on factors outside of what the NHS or what a health system addresses. So if you look at, this is the sort of original famous rainbow, social determinants rainbow that a lot of public health people will use. So that sort of core where the people are standing is, those are our, that's our DNA, that's our physical bodies. But when you think about your own health, think about the people around you in your neighborhood, in your workplace, think about your workplace. There are other things that affect us and affect our health. It's about where we live and the houses we live in. If we're thinking about work, it's about that commute, when we did commute, but how far it is, and that journey there, and how you're taking it. Are you taking active travel? Are you not? Can you afford to? Is it accessible? What's the, it's about the food you eat. It's about it's the type of job you have and the stresses you have. So it's all of those factors are also influencing your physical and mental health. So we talk about the social determinants in our work, and we're talking about all of that range of factors which we know are influencing how we're living our lives and that our health outcomes. So those are the social determinants. We'll come back to those as we talk over the next couple of hours. Next slide, please. So people sometimes talk about the social determinants, but sometimes that sounds a little bit complicated. So the Health Foundation, who are another think tank, talk about the building blocks of health. And that might be easier for some people to think about, just to think, okay, well, what makes me me? So my work makes me me, my education makes me, builds the layer of who I am, the food I eat, the amount of time I'm out talking to people and friends and family. Am I lonely? Am I feeling isolated? Am I making that effort to get to know my community, to spend time in my community and get that sense of community, which we knew during COVID, the ONS had quite a few measures when we had a bit more time to think about these things, to value how important these things were. But also transport. Again, we're going back to, do I own a car? Am I depending on public transport? All of these things are influencing my health, my physical and mental health, and of course, my housing. So these are all really important things that build our health, like a child playing. And then it's really important also just to also think about, one of those key factors, or the key block, maybe the biggest block there, is our income. And all of those building blocks in many ways are related to that key block, which is income. And it's important, if you go away with one thing today, I'd quite like it if you would go away remembering what's happened to incomes in the UK in the last year. We know that the cost of living crisis, or it's the cost of living state that we're in, I don't really like to use the word crisis, has really put pressure, particularly on people living on lower incomes, to live their lives, never mind living a healthy life. It's the stress of just living day to day. And that's just how inequitable the pressures are, is that in 2022, for the median disposable income, otherwise it's kind of like average if you're not a maths person, right? But your median disposable income, for the poorest fifth of the population in the UK, it decreased by 4%. In 1 year, your disposable income decreased by 4%. And for the richest fifth, it increased by 2%. That's the inequality we're talking about, right? What if we all decreased by the same amount or all increased by the same amount? And that's not what's happening. And that's why inequalities are growing. And that's why you're seeing more people coming into some of your services, because the poor are getting poorer. There's evidence the poor are getting poorer and the rich are getting richer. Please, if you remember one thing, that's the one thing to remember. We have evidence that in the UK, the poor are getting poorer and the rich are getting richer. Next slide. And what do I mean by this? You know, what does that mean for the people who are in this room working in local councils or working in the NHS, right? Let's be really specific about the building blocks. So let's take that building block of what we eat, right? So let's think about the people in that poorest fifth, right? Again, that's the fifth. So there's a lot of people in that fifth. If we looked at the poorest 10th, we know that those incomes are even lower. But let's look at that poorest fifth who've lost in 2022 4% of their income. So, sorry, someone's not on mute. If you could just check. Thanks. And so at the same time as incomes decreased on that lowest for the poorest by 4%, you can see the price of all of these food staples have increased. Right, so apples, carrots, things you'll be feeding children, cheese, milk, chicken, all of these foods. They're not special foods, they're not fancy foods. These are basic essentials, have all gone up by huge amounts. And even those budget ones, this is a nice piece of research that Which did, you know, the own level, you know, Tesco's Own, those kinds of prices have also gone up by 25%. So trying to make sense of, well, then what am I going to do to feed myself and how am I going to feed myself healthily? So if we go to the next slide, great research being done by the Food Foundation. But let's look first. This is pre-pandemic, right? So who's eating 5 a day? Who's reaching those 5 a day, that recommendation? It's sort of almost a minimum recommendation. So we know before the pandemic, before the price rises, right? It was the wealthier parts of the system, but even they're not meeting the England average of about 55%. That's still not a great average for all of England. But what you can see is in Knowsley and Halton and Liverpool, it's already less than half of people are doing that. And we know there's inequalities in that. So if we go to the next slide. So the Food Foundation, again, doing some great research on what food poverty actually means. So this is in January 23, so it's a year ago. So we know that price rises have continued and they've stayed high and incomes have stayed low for those in the lowest incomes, that people are buying less, right? So if you're food insecure, there's, you know, slight variation in definitions here, but if we just talk about these are people who are living in food poverty, they're already making choices. That's half of them eating less fresh fruit, more than half eating less fresh fruit, and more than half eating less vegetables. So, you know, these are huge numbers that we're storing up problems if the people in some of the lowest incomes are eating poorer diets. So if we go to the next slide, we can see that it gets worse when we look at these statistics by ethnicity. We know that these groups are more likely, people from Black, African and Caribbean ethnicities are more likely to be food insecure compared to white ones. So, you know, there's complexities to this, which are storing up problems for the future. So it's not going to be all bad news, I promise you. Next slide, please. If we look at how the NHS defines health inequalities, this is their health inequalities are unfair and avoidable differences. That's the second thing I would like you to remember. If you only remember 2 things, is to remember that these are entirely avoidable and they're unfair. And I think we're allowed to talk about things not just because they're happening, but whether or not they're right or wrong, and what is your own role and our role in trying to avoid it. So it's those unfair and avoidable differences in health. And we talk about how long people live. You might have heard Michael Marmot or our team talk a lot about life expectancy. So if we go to the next slide, what we can see is that this is one of the slides in the Cheshire and Merseyside report, which is looking at your deprivation score on the bottom, or And then on the side, it's your life expectancy. And we can see the places that are wealthier have longer life expectancy. Now you might say, yeah, okay, that makes sense to me, but it really doesn't have to be that way. And that depth of the life expectancy, the difference between the most deprived and the least deprived differs around the UK, in terms of sometimes it's steeper and sometimes it's less steep. But here, is it fair that on average women in Knowsley live to about 79, 80 years, and in Cheshire West and Cheshire East, it's closer to 84. Now, that might not seem like a lot, but if we look at healthy life expectancy, and let's go to the next slide, it's not just that they're living longer, but they're also living longer and in better health. So this is a really key one for us as well. It's not just life expectancy, but healthy life expectancy. And so let's go back to Knowsley, right? It's not at the bottom, but these women were living on average to about 80, but when they stop being healthy, on average is about 58, 59. So that's what, about 20 years in poor health compared to women in Cheshire West, who are living about, say, 10, 12 years, or about 12 years in poor health. So there are differences in the quality of life as well as the length of life. It's the quality of life that you're leading as well. And these are things that we can measure, and that change isn't quick. So we often try and have shorter term measures to look at, because this one can take a while to turn around. But what we can see is, if you look at national figures, life expectancy has fallen, yes, since COVID, but it was falling before COVID. And we can see that that wasn't happening in other countries, similar countries around the world. So let's move to the next slide, because what we want to do is we want to talk about some of these conditions that many of you on the call today have control over, those conditions that make people sick. And this is the work that Michael Marmot did, and it's based on a work that he, as a doctor in emergency, could see the churn of patients coming in and feeling as if he had very little control over what he was trying to do to help them, because he was sending them back to the conditions that made them sick. So what does that actually mean? If we go to the next slide, again, we're going back to these building blocks, isn't it? So these people, in your A&E doctors, or perhaps maybe we're talking about some of the I know there's a few counselors here. You have people come in and asking you for help, and you may be limited in the tools that you have or the advice you can give, because you're sending them back to the conditions that are making them sick or unhappy. So it's about in your role, how can you make sense of what makes us happy as a society, what can make us live longer and better lives, and what influences those building blocks that make us healthy. You may not be able to get rid of fuel poverty, but there are interventions that you can, and approaches that have been taken locally to try and ameliorate some of the effects of poverty, or, for instance, some of the effects of fuel poverty. So if we go to the next slide, let's go into what can you actually do. We talk about it in the Marmot themes. We talk about the Marmot 8. We are always talking about giving children the best start in life. And then we go through sort of the life course, take a life course approach, talking about, the importance of education, good work, a good income, and also the importance of housing and neighborhoods. The role of the NHS is there in that 6th principle. And then we really wanted to specifically talk about racism and the impact that is having as a result of the research that we did during COVID. And then really trying to draw out climate change, which was getting sort of lumped in as a tick box. And we really wanted to draw out some of that. So those are the principles that we're talking about here. So when you look at our report, you'll see that there's recommendations there and all of those key principles. There isn't a panacea if you just do one thing, which people often say, if we just did one thing. Well, I would say if you just did one thing, it would be to give every child the best start in life. But that requires a whole bunch of interventions, which involve parents, education, and healthy communities. So it's all connected. Next slide, please. And that's what the recommendations look like. We've got a lot. and different places across Cheshire and Merseyside are doing different things to address these recommendations. And I think Alan may talk a little bit about that later. Next slide, please. Let's not forget that the NHS have this strategy, that Core 20+5, which goes, it's great. It gives the NHS a focus. Does it deal with the social determinants of health? Not too much, but it's not necessarily supposed to do that. But it's definitely a tool in the belt for healthcare systems to address health inequalities and really think about the services they deliver and the way they work with communities to try and reduce health inequalities. Next slide, please. And we talk about proportionate universalism. We don't just talk about universal services. We say, go back to that bike image. It's not just that universal service. It's about saying, well, how do we specifically target and proportionately target services funding to really try and tackle the inequality? You're not trying to, make people come down and have worse health outcomes, but we're trying to get people to, we use level up before lots of other people use level up, but to level it up, those outcomes in health. Next slide, please. And what do you need to do? I mean, and I think, we often can see a lot of funding for innovation. This is what governments love to do. And as much as we try and say, look, a 6-month project here, a 12-month project here isn't going to reduce health inequalities. It is about doing things differently. And it doesn't mean sometimes a small tweak is necessary. But if we go to the next slide, it's not also just waiting for a moment of clarity and saying, if I just read this one report, all of the answers will be there. Next slide, please. It's about thinking about all of the actions that you're taking, the services that you're providing, and thinking about, is what I'm doing going to worsen health inequalities, or is it going to improve it? Is it going to amplify inequalities or mitigate it? And if you click again, you should get this. It's about prevention, and that's what we're talking about. And at a time like this, when councils and the NHS are under pressure, that thinking about whether or not prevention is possible, it's not about having a whole new campaign for smoking cessation, but it's really about, for instance, and thinking, I can't do this because it all costs too much money. It is about thinking about the existing funding that you have and really thinking about, is it worsening? Is it amplifying? Is it mitigating? Is it improving? Asking you and your staff all of these questions about the services that you're providing. And the next slide, please. And it's really, to go back to the point about innovation and boldness and clarity. If we look at all of these so-called lifestyle choices, we're talking about smoking, alcohol, and obesity, right? What we can see is there's a social gradient in outcomes, with the worst outcomes in the areas of high deprivation. We know that the routine and manual occupations smoke more. We know that alcohol-related mortality, whilst consumption might be a little bit higher in some other income categories, it's the mortality which is worse in areas of for people living in areas of high deprivation, and the same for obesity. And what I can tell you is, if you go back and look, for anyone who's worked in your job for the last 20 years, these will have looked the same for the last 20 years. So if we keep tweaking and just doing small things, these inequalities in smoking, alcohol, and obesity will persist. Is it about doing something different and being bold? And I realize that there are budgets that are small, but it is really about thinking about what you're doing and saying, is what I'm doing actually going to reduce health inequalities, or are we just going to keep doing the same thing? And that's what I'd like you to think about, and to give you some space to think about that today, about changing the outcomes in these slides. Next slide, please. And then, wow, I timed that well. Sometimes, you can go on about things, and sometimes you actually, I'm here and I'm ready for the quiz. But if there's if there's a burning question right now, I could take one or two, or we can just, I didn't want you to fall asleep, so we're going to ask you some questions here to start a conversation. How about we just go straight to the first? Hopefully after that, if there's not a burning question, we're going to, and I can't see a burning question. Hopefully, this is a test to make sure you're all paying attention. Can you give us, this is the old QR code, which I admit I'm not the best on these QR codes, but we really do want to get you thinking about things. And we're asking, I'm going to tell you exactly why I'm asking this question. And I hope Alan thinks this is the right thing for me to do. But when we talked to the Altogether Fair leads, so our report in Cheshire Merseyside was called Altogether Fair. There are now one of each of these leads in each local authority in Cheshire Merseyside. And we met with them last week. We continue to meet with them about every 6 weeks and hear about all of the actions they're taking. And we asked them, we said, what question should we be asking the people attending these workshops? And what they wanted to know is if you understood what the social determinants are. So I'd love to be able to go back and show them this slide and say they understood it. So can you please go onto this Mentimeter and use the code, or use that QR code and tell us what you think a social determinant. Give us an example of a social determinant. Hopefully, I mean, I did just tell you and talk about it, so hopefully you're all there and Hannah's going to come up with a good list.
We'll just share it on screen momentarily.
Okay, I'm not going to give you any hints, but just to say, I once sabotaged a Mentimeter in a presentation, so I'm ready if somebody sabotages this and says, I don't know, basket weaving or something. Like, well, basket weaving I could say is a social determinant. No, it's not. Let's hope that I can't see anything. Can anyone else? Not yet. No. Okay, can see. It's like a drum roll. Is something coming up, Louise or Hannah?
Yeah, it should be. If not, I can share the screen afterwards. Oh, there we go.
Yeah. Okay, phew. People were listening. Good. Yes, education. Yes, massive inequalities in education. Well, I'm not smiling because of that. I'm just smiling because you know that. So we know that kids eligible for free school meals, even at the age of 4, when they're entering into reception, or at the end of reception going into school, at the age of 4, we know that there are vast inequalities already. So those children eligible for free school meals are doing worse on that good level of development compared to those children not eligible for free school meals. And that continues into primary and secondary. So housing, healthcare, environment, income, access to green space, housing. I wouldn't say, I'm going to challenge, I wouldn't say deprivation is a social determinant. I think it's, Alan, would you say, I'm going to come to Alan Higgins on this, would you say deprivation is a social determinant?
I guess it's more a consequence of the determinants that people end up in deprivation, but I could easily argue the other direction as well. But it's certainly one that would be in the ballpark, I think.
Okay, in the ballpark. Okay, yeah, ish. Okay, but bravo to all of you for getting that right. So let's go back to the proper quiz, and we can have, I'm happy to be interrupted in the rest of the quiz as we get going. It's supposed to help us have a conversation about what we've just discussed. So if we can go back to the slides, please, and we'll get started on the quiz. And the first question should, I'm not getting, no one's going to get tested. You're not going to have like 3 out of 4 or anything like that. It's just pride for yourself. So the next slide is, which one is equity? Is it the one on the left or the one on the right? Does anyone want to put up their hand and tell us? Anyone? Okay. Who has just said? Angela Coleman, Councillor Coleman. Which one is it? One. Okay. Anyone else besides Councillor Coleman? Because oh wait, we can hear you. Yes. Oh wait. Oh, you've put it in the chat. Yes. Okay, Laura. Yep. Okay, it's the one on the right, because equality is when we're all trying to reach that apple tree, the fruit in the apple tree. And I am 5'5" and I can reach a certain amount of fruit, but I can't reach as many as Alan Higgins, who's a little bit taller than me. And so in order for us both to equally have access to those apples, I would need a slightly higher box to stand on. So we've adapted the tool with which I can use compared to Alan. So yes, hopefully that is sticking in terms of equity, and why, not just what it is, but also why it can help make life more fair. Right. Okay, tick. Hopefully most of you have got the difference between equity and equality. It did take me about 3 years to do that. Right. Okay, so I've talked about the difference. Don't click the button yet until I tell you. I'd quite like it if you could guess this. I think, so I've told you that the difference was about 4% less and 2% more. So what was the median income fall? How much? So I told you it fell by 3.8%, I think it was, and it increased by 1.6. But what does that actually mean in pounds? How much did the median income fall in 2022? Before we click the answer, can anyone guess? Maybe you can put it in the chat or feel free to shout it out. How much did that actually mean? Anyone? Okay. If we go, no one wants to chat, you're gonna have to chat more at some point, but let's go to the answers here. Right, so the poorest fifth of the population in 2022 in the UK lost more than £500 of their income, right? So go back to the point about all of the price increases that we saw, right? Just in food alone. Don't think about energy, but then maybe think about energy, about how much more all of us paid for everything. Now put yourself on that lowest income, you've lost on average £570, compared to the people in the wealthiest quintile who had their incomes on average increase by £1,000. So that's to give you a sense of the choices people are making when they're trying to pay for those building blocks of health. They're trying to manage those budgets with less money. That's hopefully sticking in heads, that, you know, when you're talking to people in clinics, in surgeries, whatever it is, surgeries, whether they're from local councillors, I mean, you'll see it day in, and you'll know better than me that people have less money than they used to. Right, okay. Income. So let's talk about the impact of income. So let's talk a little bit about digital inequalities, because a lot of services in the NHS and local government have had to force to go to digital services because it's cheaper, right? So if it's cheaper, what does that, will it have an impact? And this was something that we have a little bit about in our Cheshire and Merseyside report, because I know they've tried to do things a little bit differently and have some key hotspots where people can use, can access broadband for free in parts of Liverpool. But just to have a bit of a think about what the cost of broadband was. And I remember when I did this research, I did it for a report we did in Waltham Forest. I hadn't even clocked that prices had gone up because I have as you know, my income is at a level where if it goes up by a few pounds in a month, I don't necessarily clock it myself. But for people who are on low incomes, right, if we think about it, their incomes have gone down. But then we've got something like broadband, which is regarded, especially if you've got kids doing homeschooling or you're working from home, what does it mean? So the cost of broadband in the UK, how much did it increase or decrease by in 2022? I'm sure you'll all guess it did increase. Does anyone want to guess? Anyone? Okay, no one wants to guess. Right.
20%.
Okay, Matt is closer. I think Matt is closer, but actually I think for one of them you maybe, let's go to the answers. It depends on the provider, and this is also continued on in 2024. If you look at some of the more recent, so it continued to rise in 2023, and it was expected to rise, I think, by about 20%. But the government stepped in the last month or so and said that they would try and control some of the increases because it's just gone up so much more than inflation in the last few years. It's ridiculous that these companies are making vast profits, and it's been unnoticed, never mind unregulated. It's just gone up. So finally, there's been some sort of government reaction, but that's not before a lot of increases have already happened in the last few years. So, really that last point about for a family claiming universal credit would expect to spend 8% of their income on broadband, 8%. And there's research that went out and asked, one of the universities went out and talked to people living on low incomes and said, rank, if you have this much money and you want to spend this on, on broadband, how are you trying to budget it? And something like, I think it was like a third of people were not spending money on food in order to spend money on broadband. So these are the choices that people on universal credit on low incomes are having to make is, what am I shifting? What am I making a choice for today? So it's just important to think about when you're thinking about, I'm going to, maybe for some of you hiring, expecting people to do interviews online, and, that cost to people when you're hiring them, and is that equitable, right? So that's digital inequalities, right? Okay, now I'm going to test you on your smoking prevalence. So which local authority in Cheshire Merseyside has the worst smoking prevalence? Feel free to use your own or shout loud and proud that your smoking prevalence is good or bad. Anyone?
Knowsley?
One for Knowsley, maybe. I'll tell you it's a tie between two people. So maybe Knowsley, but I can't remember at this moment. I think Knowsley might, but who have they tied with?
Sefton. Or South Sefton.
Sefton? I don't think it's Sefton. What percent what's the prevalence? If we think of the place, what's the prevalence? Clatterbridge Cancer Centre, they should know. Okay, so we've got Knowsley, Halton, Sefton, maybe, but what percentage of the population? I think this is from, I think it was 2019. Anyone? 30%. Maybe if we included, I don't know, maybe if we included vaping, I don't know, 30% seems really high. I don't think it's been that high for a good few years anywhere. Okay, let's go to the slide. So it's Liverpool and Knowsley. Right. It's so funny. There's so many smoking prevalence statistics. We could probably do like an hour on smoking prevalence statistics and how they sort of slightly differ according to who is asked. But nonetheless, we know that areas of high deprivation, Liverpool and Knowsley have the highest smoking rates, right? But St. Helens and Halton, yes, are up there. Sefton a little bit lower, but look at that, Cheshire West and Cheshire East and Warrington, And in some ways, if we think about something like smoking cessation services, right? So these numbers, and public health people, feel free to talk about this, but these numbers have looked fairly similar for a good few years now. It's almost as if that sort of, we've got people here from the Clatterbridge Centre, but, we've got that low-hanging fruit in a way of smoking cessation has been had. And now we're at the point where it's really targeting people who are, it's targeting young people and smoking. We won't get into the vaping issue at the moment, but it's about thinking about how do we take these smoking cessation services and really think about reducing the inequalities in that. Really, do you need a universal service in some of these areas? Somebody was just talking to me this morning to say they are being forced to radically cut their smoking cessation services because of the cuts they've had in the NHS. So they're just saying, okay, well, we have to do this completely differently because we cannot do what we've done in the past. And maybe in some ways it's a good thing because these statistics have looked fairly similar for the last 10 years or so. So they've gone down and it's a great thing, but they've sort of remained at a stubborn kind of just a little bit less than 1 in 5 for many years. So interesting statistics. Right. One final question from us, and then, oh, right, the England statistic, 14%. So that's, you know, 1, 2, 3, 4, 5 local authorities in, well, 3 local authorities worse than the England average, and 2, well, 2, 3, 4 at the same as the England average. So some of you doing worse and some of you doing better. Right, one final question, and if anyone has any questions before we go, does anyone know who this is? I'm going to wait for an answer here. Anyone? Not the best picture of him. He's local. Well, he works in one of, I don't know, sir. He works in one of the hospital trusts in Liverpool.
Have a look at the chat.
Oh yes, Helen. You're right. Helen, can you tell us why you think you know that? Do you mind?
He's quite vocal on the smoking front and in the press a lot. Really proactive.
That's right. It's Dr. Ian Sinha. He's a consultant respiratory pediatrician at Alderhay. And when I was doing our work for Cheshire Merseyside, I was at a meeting on anchors, and I met a crazy woman on a bike who sat for an hour talking to me as she cycled from home, doing her exercises during the pandemic. And she told me about this amazing man called Ian Sinha. And as a result of that meeting, I ended up writing a report with Ian and one of his PhD students, because Ian is an absolute inspiration. And I also hope that if it's number 3, there's one thing you remember is how great Ian Sinha is and the work that he's doing at Alderhay and wider. Ian was at work and had many children come in and talk to their parents and talk to them about the quality of housing in Cheshire and Merseyside and wider. And Ian decided that he was going to do something about it. So he picked up the phone whilst the parents were sitting there, and he called the council or the housing association, and he said, I've got my patients sitting here in front of me and their housing is really poor, and they've just told me some stories about it, and it needs to get better. And time again, what he was told by families was that they'd been complaining many times, many of them, and nothing had happened until he'd actually made that phone call. So Ian said, just like Michael Marmot said, I'm sending my patients back to the conditions that are making them ill, and I want to do something different. So he also did something great, is he decided that he was going to work with parents to try and get them to educate each other. So he has, in this report that we published last year, I think it was, there's a great case study in there called something like Parent Champions. So his PhD student Alice works with parents, trains them up, and they talk to each other about good health and housing, things around housing that come up, to get them to talk to each other about their children's asthma and how to take better care of their children who have quite bad asthma. So it's not just that he sort of took a sort of personal responsibility as a clinician, he also thought that he would try and work with parents to educate them and allow them to educate each other. And I think it's a really nice example of sort of ceding power and saying it's not just all with me, telling them what to say. He's like, I'm going to use them to talk to each other because they're the best advocates that they can be for their children. And we did a nice piece of research and looked at, this is household expenditure. And here you can see again, I mean, let's go back to our how much of incomes decreased for people on that lowest quintile, and you can see here this is by decile, but they're spending as a percentage of their total expenditure for people on, in the most deprived places, they were spending 8% on their broadband. Well, they're spending almost 8% on their gas and electricity, and that was in 2020 before prices shot up. So we know that that number is going to go up. Unfortunately, fuel poverty statistics take years, often 2 years too. So we won't know the impact of the last winter until for at least another year. The statistics that come out this year will be from 2022, I think. Yeah. Anyway, so that was the delightful Ian Sinha. And yes, there's the rapid mobilization of parent champions. That is a great case study in that report, which is on our website. So there's our quiz. I hope you did really well. Any burning questions before we take a bit of a break? Right. I'm mildly worried at how quiet you all are, but hopefully that will improve after you take a break and make a cup of tea or whatever. And we're coming back and we'll reassemble at 3 o'clock. And hopefully we'll have some discussion, a wider discussion about what we've just, I've just discussed for the last 48 minutes. So I'm really happy to take a break myself, and I look forward to hearing your thoughts on all of this at 3 o'clock. See you then. Whilst there's a small group of us, if we could just go around and introduce ourselves, and then we know who is here and who isn't here. So I'm going to do our team first. So Alan, can you just, I'll do Alan.
Hi, Alan Higgins. I'm the strategic lead on implementation of the Altogether Fairer programme for the Champs Public Health Collaborative.
Okay. Hannah and then Louise.
Hi everyone, I'm Hannah Sharp. I'm a public health practitioner at the CHAMP support team working on population health.
Louise.
Good afternoon everyone, I'm Louise Vernon. I'm the programme manager for Altogether Fairer at the CHAMPS Public Health Collaborative also.
Thank you. Okay, I'm going to go to Clatterbridge because I met John and then I'll go to Joe. So John.
Hi everybody, I'm John Hayes. I'm the Managing Director of the Cheshire and Merseyside Cancer Alliance, which is hosted by Clatterbridge, but technically isn't actually Clatterbridge.
And then Joe?
Hi, I work alongside John at the Cancer Alliance. I'm the first health inequalities and patient engagement lead that a Cancer Alliance has had in the country. We're 2.5 years in post now, so the Alliance takes health inequalities extremely seriously. I now manage a team of 5. Focusing on health inequality and cancer.
Wow, that's great. I don't think, I don't think that existed yet when I first started working in Cheshire and Merseyside. I'm going to go to Knowsley first because I know that we've got Richard and Councillor Arnell, and then there was another councillor, but I'll ask Councillor Arnell to go first and then Richard.
Oh, there you go. I'm Councillor Del Arnell. I'm the adult social care portfolio holder for Knowsley Council. And I've got Chris Bannon with me, who's our health portfolio holder.
Okay, Richard.
Yeah, and Richard Holford. I'm the consultant in public health at Knowsley Council, leading on health inequalities.
He also sits on the Altogether Fair group, valued member, right? Is there anyone else from Knowsley here before I move on?
Hi, I'm Mary Cronin. I'm a public health registrar at Knowsley.
Okay. And then I'll go to Wayne Longshaw.
Hi there, Wayne Longshaw, Director of Integration for Mersey and West Lancs Hospital Trust.
Okay. Is there anyone else here from Mersey and West Lancs? Okay. Julia? Or Julie, sorry, not Julia.
Oh. Hi, I'm Julie Gallagher. I'm Associate Director of Transformation and Partnerships for the ICB in St Helens Place. And I think there's a couple of other St Helens colleagues on, including Wayne.
Okay, I'll go to Lisa and then Stephen then, because I can see.
Hi all, Lisa Ellis, Associate Director of Quality at St Helens Place.
Okay. Stephen?
Yeah, I'm Steve Woods. I'm Head of Strategy at Cheshire and Merseyside ICB, working with Alan on the alignment of our care partnership strategy with Altogether Fairer.
Right. I'll go to Charlotte and then Councillor Coleman.
Hi, Charlotte Walton, Executive Director for Adult Services at Cheshire West and Chester Council.
Welcome. Councillor Coleman. I can't hear her. Can anyone else? No. Okay. We'll come back to you, but I'll go to Matt and then Claudia.
Hello everyone, I'm Matthew Parker, I'm Managing Director for Brio Leisure. So we're a wholly owned council company in Cheshire West and Chester, delivering leisure, but also a range of wellbeing programmes as well to support with improving population health.
Valued member of our social determinants, building blocks of health, isn't it? Let's hope that they are affordable. If they used to be free, but now hopefully they're affordable. Claudia?
Hi everyone, I'm Claudia Soylan Reyes. I'm Public Health Manager at NWAS, the Northwest Ambulance Service. I've been in post for almost a year now, after the placement of a few public health registrars at the Trust, which has been driven by the work from the AAs, the Association of Ambulance Chief Executives. So yeah, this is precisely what we're trying to do, what you're doing, Tammy. So it's very helpful to see the approach you're taking. So keen to learn and share what we're doing.
They are. I remember I met some of your colleagues when I was in Cheshire and Merseyside, and they were doing some really interesting stuff. Councillor Coleman, and then I'll go to Iforma. Councillor Coleman? Okay, still not working. Iforma.
I hope this works. So I'm Iforma Onya and I'm Director of Public Health at Hope Borough Council, also having IT issues.
Okay, welcome. So we've got two experts here, so we can depend on them. And then Mary, I don't think I got to you, Mary or Lisa.
Mary Cronin from Knowsley Council, Public Health Registrar.
Oh, sorry, Mary, we did get you. Okay, Lisa. Lisa? Okay. Well, we'll just leave Lisa and Angela. We'll leave all of the difficult questions for Lisa and Councillor Coleman. They can do semaphore. Right. Okay. So our first question is, and we'll sit in an awkward silence if hopefully we've done our introductions, but I guess I wanted to ask you, actually, I helpfully don't have the, I'm trying to think, I guess I really actually do want to say, are there any questions raised on anything, or is there anything new or any other questions that you have? From anyone, anything? Does it all make perfect sense? Okay, I've got a couple of nods. Claudia.
Thanks, Tom. Yeah, I think from the first part of the session, it just was very like a big finding or new thing for me to, you mentioned that out of the, and correct me, I may be wrong, that one of the biggest determinants of health or all these disparities in health, the highest impact is due to income. And I was thinking, well, yeah, I think, was that what actually you refer to, that is income what is kind of driving mainly all these health inequalities? Or I misinterpreted, because to me it's a big thing to refer all that health inequalities to income. So I don't know, just wanted to clarify that was something that kind of was burning, I think, for me.
I mean, what do other people think based on that question? Charlotte, I'll come to you.
Yeah, it wasn't just in relation to that, but I think it's stark, isn't it? And the, you know, the fact that it is fact that, you know, those on lower incomes, their income is reducing and vice versa. But I suppose the bit I just wanted to throw in was the comment you made about, was there anything new? And I think for most of us, we'd say there isn't. So that raises the big question, doesn't it? You know, we've known these things for a very long time. So that's our question and challenge, isn't it? But some things like income, which is key, are getting worse, and we know it as fact.
Okay. Joe?
Hi, I just wanted to talk about something that that we're doing and had some success with, and I just think that there's we have on these calls you often find the teams that are really committed and are confident to tackle health inequality in their work, And we've recognised that there's loads of staff that really want to do this, but don't necessarily feel confident or have the skills at their hands to understand. You said something before about, you know, not necessarily going to ask for a lot of money or huge changes at the top. You know, what we're doing is looking at how every single staff member can change one thing in the way they work. We're using it as a tool and a training course, and we're empowering our staff to believe in themselves that actually this is more of a social movement than a top-down approach. We're having a huge success with that in terms of training clinical staff on the front line, all it at the moment in cancer services. And I think that's a gap. We look at a lot of the other things, they're really important, social determinants are vital, but a lot of the people dealing with this are just staff working really hard in their day-to-day job and don't necessarily have, they don't think it's within their power. So what we do is we kind of give that back.
Okay, can you sort of just explain a little bit for the rest of us, what do you actually train them in, and then what do you expect them to do? Okay, so I run a face-to-face 3-hour training workshop. That's our kind of gold standard because we know not everyone has 3 hours, but the aim of that is to really explain what health inequalities look like, what barriers to services looks like for local people. And the way we do that is to tell local stories. So we go out and listen to people who are missing those barriers and we share their stories. So that's the first point. So the first half of the training is very much scene setting. A lot of the stuff you've done today around information, definitions, and then what it looks like for people. And then we have a break to kind of pull ourselves together after the depressing first start. And then we come out of the ditch and we climb the hill and we look at, if they're the barriers, if they're the snakes, because I use a snakes and ladders analogy, what are the ladders that we're already using? What are the ladders we can share with each other? What are we doing about literacy? Are we sharing easy read material? And we kind of work as a group to pick one thing in the way that we work. Because I think health inequalities is just so overwhelming. People don't know where to start. So we say, right, pick something. And for the rest of the session, we design using a toolkit that we have, the way to make that happen. And people go away with that as a definite action. Often I'll say, no, you've picked something too big. Let's go back, make it smaller. Let's make it so you can do it rather than aspire to doing it. What's your time scale on it? So we're starting to give people well, they're picking themselves, but we're helping them. You can do this, you know, if your letters aren't written in the right way, can we include this? If you don't have your claiming scheme for claiming back your expenses written in your letter, make sure that's in next time you assess your letters. Have patients read your letters? Can they read them? Do you have an easy read version? But not everything, just one thing. And that's the key, and it's really started to pick up across kind of both the Alliance, across Clatterbridge and across the cancer trusts we're working with. So to go back to the point that Claudia made, is this just an issue around income?
In terms of,
I guess I'm pushing back because it isn't just an issue of income, is it? There's other things that you're suggesting. So you're not suggesting increasing incomes because you can't, can you?
We're not asking, we don't charge for our training.
No. I meant for your patients.
For our patients.
You're not even doing that.
It's much greater than income. So yeah, I mean, I will talk about, I'm from one of the poorest areas in Merseyside, so I'm really confident to tell you what that actually looks and feels like. And I will certainly do some part of that in my training. And income's a massive issue. I think health inequalities up until a few years ago was quite London centric, didn't always focus first and foremost on deprivation for some of the work we were doing. And I think it's great that we are, but we're also talking about people who say, you know, I can afford to get there, but I'm so anxious when I arrive, I can't go in. But that's a barrier. That's an inequality. That's not feeling like you're entitled to the service.
But I mean, I think it's a really good point. Councillor Arnell.
Sorry, guys, I couldn't get mute off. I just wanted to feed back a little bit of information to Jo in a first-hand experience. My husband recently was treated at Clatterbridge in Aintree Hospital, and we actually had those conversations with staff, and I, as a councillor, I was surprised and pleasantly surprised that they did ask, could he read the letters? how was he getting to his appointments? Did he need any assistance to access any services, and what kind of what help he had at home? And those questions, that was the first experience I've had of that, but it was invaluable, and it was really reassuring that service, so it's working. Keep up the good work.
Thank you, because I trained that team quite recently, so it's a really important piece of work we're starting to work. It's great to have that feedback. Thank you.
You're very welcome. Thank you.
So that's an easy. It's a kind of okay. So how much did that cost you, Joe? I'm trying to get at here about, this is something that other systems can take away, isn't it?
Yeah, so it costs my time. Obviously, my team has grown. One of the things that costs us money is listening to patient voice, but really listening. So not listening to people who are the people who choose to come forward, because we know about their voices and we know who those people are. What we do, we go out and find people we don't hear from, and we go and ask people who don't use services why they don't use them, because we use that in our other work. So it's very hard to pin down what the cost is of this, because we use patient voice in improving every service we work on, but we also use that to inform our training. So we're currently devising an e-learning. We're packaging lots and lots and lots of patient voice into an e-learning 1-hour session, which will be available free of charge from the summer. So that will be available for everyone across the system to access, which really funnels this change one thing, really funnels this take an action yourself.
So let's go back. I'm going to wind back, Charlotte, to the point that you made. We know the things, we know what can be done. Do you actually know what can be done or needs to be done?
So I think the point I was making was we know the things that make a difference in terms of the the elements, the building blocks,
the problems.
Exactly. So I think we're very good at articulating. So the question is, and it's not to say things aren't being done, because there are some great things, and we've got in Cheshire West, we've got our community inspirers doing fantastic work, but it's bigger than that. So I suppose it's back to every time we look at this, we know what the building blocks are and what has an absolute impact on somebody's quality of life, life expectancy, life experience, etc. So collectively, what are we committing to, and I suppose what are the key things that are achievable, because we're not turning the dial in the right direction, are we, overall? So I suppose it's putting that question challenge back to us all, really, isn't it?
And I think it's about I think that's where not innovation, because I hate the word innovation, but where change happens is when, isn't in the example of Clatterbridge, and I'm going to come to you, John, in a second, or those cancer services, or what Ian Sinha did, is going out, and I've heard examples of this from across the country, of asking patients why they DNA, why these lists, or why people aren't coming, and simply asking those questions instead of assuming what the answer might be. And even I can be accused of assuming what I know the answer to be. And I suppose that's why people say, just tell us what to do. Just tell me 3 things to do and I'll do it. And I guess my answer often back is, as Joe has just explained, is to go and talk to these people and sort of listen to what needs to be done. What is preventing people from eating healthily, and if it is about the cost of food, let's talk about food and cancer, then is there a limit to what a hospital can do? But there are things, making local partnerships, or somehow talking about being realistic instead of just telling people to eat healthily. It's about eating healthily on a budget, or some kind of guidance like that that's more realistic. John, can I come back to you?
Yeah, I think you probably said what I was going to say, really, that I think we know in macro terms what are the social determinants, but actually it's so important that we don't assume in every case that we know what the barriers are, and that's why it is so important that we work to listen to our communities, and in many cases step back and empower our communities to break down those barriers for themselves, which I think is really important. And I really like the story of Ian Sinner, because I think, I mean, obviously he is a consultant, but I think everybody within whatever setting we work in, I think sometimes we are shackled to what we think our job role is. And so we might assume that we don't have any influence, or it's not our job to go and resolve an inequality, even though we can see it very, very starkly. So I think, you know, the lesson from Ian is really, really clear, isn't it? It's not his job to sort out housing according to his job description, but it is his job to try and influence housing, because it's just a moral duty to look after his patients in that way. So I think all sorts of learning. So, I mean, basically, or what I wanted to say is, you know, let's not just fixate on the big headline determinants of health. Let's use every single minute of every single day to be a discovery and learn more about it. And when we see it, we call it out.
What I want to just pick up on that. I'll come to you, Richard, now, but I just want, as I come to Richard, to think about John's challenge about it's not Ian's main job to improve housing, but it's his moral duty. And I suppose to think of it yourself about, do you feel that sense of moral duty? Because there were a lot of different jobs here. I suspect. Anyway, Richard.
No, I mean, I was going to pick up on that. I think John's totally right. I think one of the things I've reflected on when I've worked in Knowsley in particular for a long time is that actually, unfortunately, partly driven by austerity measures and pressures, not just on councils, but on all partners, that added value stuff of the discussions that John is saying is what's gone down. So people have got less time with patients, less time with residents, or whatever it may be. And we unfortunately have gone less outcome based in terms of services that are provided, and more let's get them in and out really quickly, support their needs, but it's their immediate needs in terms of almost like this isn't good with the NHS, but, you know, it's like a treatment service rather than looking at the others. So it's only when we actually go beyond that they will make a real difference. I wanted to make my other key point was just around, obviously Knowsley featured really badly on a lot of those. And I've just wanted to pick up on the point, I think you made this, Tammy, is it's going to take a long time to make an impact on these. It's very complex. It's not a simple thing about income. There's cultural norms. There's all sorts of factors. And nowhere stands still. So actually we had lots of investment. I'm talking over 10, 15 years ago, like as a trailblazer money, there was across the country. And we actually saw a massive reduction in the gap in terms of health inequalities between Knowsley and elsewhere. Now, that isn't to say we got better than anywhere else, but we saw the gap reduced. And that was a combination of investment in stuff that was health related, clinical stuff, but it was also about changing behaviours really. And I think what happened then is we've had this disinvestment, and I think COVID's going to make things worse, unfortunately, exacerbate those issues. Is some of those gains have now been lost. But I wanted to put that point about things have changed over time. So like Knowsley's improved education outcomes over time,
yeah,
but so's everywhere else. And so our gap has remained the same. We've still remained worse. And I think sometimes we think we beat ourselves up that we're not doing things right. But actually, I can tell you now, Knowsley, when we had the Marmot report, we're doing almost everything that's in that Marmot report and some. And so it is, how do we think differently about some of those and challenge ourselves? And that's what we've been doing. But I just wanted to make those 2 points. So I think John's totally right. That added value's gone. And I think that's really important. It's got to be everyone's business. And that thing about reducing the gap, I think is really important, and not standing still.
Yeah.
Thanks.
And I think it's, you know, I think we do have to admit it's harder for some places like Knowsley, you know, because the level, your gap is, it's just bigger in terms of numbers, isn't it? You're starting from a worse position. But Richard, can I just go back to you to sort of talk to Matt? So Matt is here from Leisure Services to talk a little bit about some of that funding that's being lost and the impact. I mean, I guess I was interested that, Matt, you're here because we have somebody from Active Cheshire and I think it's called Merseyside Sport who come to our Altogether Fair meetings, and we talk about physical activity and the good work that they're doing to try and get different kinds of groups exercising. I mean, Richard, for that loss of funding, and I know there's some councillors here, you know, councils have their hands tied behind their backs in terms of funding, but the difference that those costs make on some of your residents. I'm not sure what my question is, Richard.
Yeah.
Or Matt.
I mean, I'm quite happy to come in because it was just about to raise my hand, so it was a good sort of introduction, really. You know, everything that we've talked about is just manifesting itself in terms of what we do. You know, we're constantly looking at the bottom line. The council, rightly, because they have to look at our financial impact on them, because it has significantly grown through COVID and subsequently. So they're keen to sort of reduce that funding support that they provide back to a level where it was pre-COVID. But during that time, we've, you know, had massive increases in energy. There's the cost of living crisis, so people have got less disposable income. So we're trying to generate more commercial revenue, whilst also as a sector trying to be better positioned to work with health to address some of these inequalities that we're talking about. But we're having conversations at the moment. Unfortunately, Helen's gone around sustaining some of those wellbeing services that I referenced: stop smoking, exercise on referral, weight management, and actually looking to charge for those to make them sustainable. And it's trying to find that sweet spot, really, because we don't want them to be, we don't want to put up more barriers, but ultimately cost potentially will for some.
Okay.
And so
Can
it's
I stop
just,
you
it's
there
just
for
a
2 seconds?
manifestation. Yeah.
Okay. So this is an example where I think we've got research from the north of England about this, but how can we, okay, so Matt, let's, as a group, we're all leaders and intelligent people, how can we try and adopt some kind of equity influence on the problem for Matt, which is a lot of council-run organizations like that who will be forced to charge for their services? How can we adopt an equity lens? And Matt, I'm guessing, I know what I would try and push, but what would I'm trying to get you to do this yourselves. What should Brio and Matt be doing in Cheshire West? Richard, do you want to have a? Richard, I'm coming to you.
I mean, it's a very difficult question, isn't it? And I think it is that, I know someone's put it in the chat, actually, it's about that proportionate universalism. That's all you can do. But I think the problem you get with a provider is the administration of these type of things. So it's either better either going free for everybody or charge the same amount for everyone. I think that's the issue, isn't it? Is that is not equitable and will cause barriers, as Matt's described. So I think unfortunately it's a really tricky situation. I think we'll have the same challenges in Knowsley, to be honest, because, you know, if I was pushing, you made a comment before, Tammy, about you know, all those, I didn't want to pick any of those Marmot objectives, but if I had to, I'd do best start to life. And I'd be like, well, I sort of agree. You know, I'd be like, every single child under a certain age should get free access to leisure and physical activity, because, you know, our obesity rates are bad, and actually if you can get them enjoying stuff like that at an early age, they might continue forever, and therefore it might be, you know, and better outcomes and all that. However, the reality is that Matt or others can't do that, and so it's how do we work a way that there's a right balance so that they get the money in that they need to run these very costly facilities, particularly with energy and swimming pools and all that. But I see swimming pools are key, are crucial, you know, in terms of a safety, community safety perspective and everything. So I've not got an answer. It's proportionate universalism, really, isn't it? But you know, so you charge what you need for that thing, but it requires being means tested, and I think that is difficult to do. And some people don't want to share that information either.
No, I
particularly
get
with
that.
a leisure facility.
And I get that. And I think, is there something, if every place is going to be dealing with this, then is there a point in, as a region, maybe the ICS or someone try and facilitate a discussion where there is some kind of agreement across the region of what's happening with leisure centres? I guess it's like if we're all having the same conversation, but that proportionate, you know, that it is important that, say, people on universal credit or something are the ones who have reduced or free access. It's just, I guess it's about it's also trying to say, at what point do you need to come together as a citywide system to say, how can we pool? Because absolutely these conversations are going to be the same everywhere. And yes, the answer is proportionate universalism, but I wanted someone else to say it because I wanted you to tell me how hard it was going to be, because I'm just a policy wonk and I don't know these things. So it's going to be hard, you know that, but you know it's important. And in the long term, it's good for the system. How, you know, it's about as leaders. And I guess for me, I'll move to sort of some comments here, but I guess really what I want to pick up on is about, as leaders, and all of these people on this call are all leaders, you know, like Ian Sinha, like John was just talking about, that personal moral responsibility you have about some of these questions. Claudia, I'm just going to go to Informa first, because I just want to pop into, we haven't heard from Informa yet. So then I'll come to you, Claudia, and then Charlotte. Informa, I wanted to catch you because you haven't said anything.
Yeah. So I guess one of the things that struck me was seeing Halton pop up when everybody was asked who's worst at smoking. And actually, we're not the worst by a long shot, actually. And that is as a result of very long-term investment in smoking cessation. The Director of Public Health before me had been a smoking cessation lead prior to becoming the Director of Public Health. And so smoking and smoking cessation was central to everything that we have done as a public health team. And I think in many ways, when you have that really concerted action, it really does help to tackle some of these issues. So that's the first point I wanted to make, and it sort of sings or marries along with what Richard was saying, that it shows that this isn't something that just happens overnight. It takes years and years and years to see these changes. We know that we're in the middle of this cost of living crisis, and we know there's some report recently that I think it was from the British Heart Foundation that showed that cardiovascular disease, heart disease, was now one of the biggest killers. It's now started to, well, I say it hasn't started to us, it's been worsening consistently since about 2012, but we're really starting to see potentially the impact of COVID on heart disease, as well as sort of lost opportunity when people weren't able to access long-term care for their chronic conditions. There's something else, though, about leisure, and I think people get really het up about, oh, we must fund these buildings with water in the middle of them and put lots of money into that. In Halton, we have an in-house health improvement team, and a lot of our focus is therefore on providing low or no cost support to the local population. We're absolutely adamant about it, that we do not charge for services, except where evidence has shown us that charging a small amount is likely to maintain that person's consistent attending. So, for example, we know that people go along to Slimming World and Weight Watchers, and they pay a regular fee, and that actually keeps them consistent and going. So using some of that learning, we do that for our weight management program. But we're also trying to identify interventions. Walking, for example, in the local community costs nothing but a pair of shoes. There's loads of local community groups that are now setting up Couch to 5K programs that are free for people to access. So I think that when we're having a discussion about access to leisure and things that will help people be physically active, that we need to think about all the components that are available for people in the community, and not just focus on these buildings that provide leisure.
I mean, for me, what's coming through as well is like the expertise that you have in that public health team. And when making these decisions about cuts, that they can bring an evidence base to it, so that these are people should be part of conversations. Matt, I want you to come back, but Claudia's had her hand up for a while, so I will come back to you. Actually, I'll go to Claudia and then I'll go to Matt, and then if there's any other queries.
Thanks, Tammy. Yeah, I think it was to go back at the question you asked about what Matt could do, for instance, and I was thinking about using the data to understand or to make it evident how these changes are going to impact on the most deprived groups. And that's not an easy task. This is something that we're trying to do at the Trust, that's trying to really harness our data, understand and show where those inequalities exist, and also to use that as a tool to communicate with our partners to say, well, this is what we're seeing, this is the people we're going to, and where the support is needed. And yeah, I think and that costs money, because having access to analytical support, that's one of the difficult parts. But it's important because the statistics you chose, Tammy, is how you change people's views. So that was my point, really.
And it's important that they're accessible and that we share them in a way that isn't just sort of in words and in pictures that data people understand. Matt, can I just move us on from leisure a bit? Would you be okay? Can you just say, make your point really quick?
Very, very quickly then. I completely agree with what everyone said, but just to give an example. So all those, at the moment, the local authority are trying to cut funding. And one of the things that they do through their parks team and their ranger service at the moment is walks. We're taking that walks program on. We're not about that for the four walls of our building. That's just one element of what we do. So we're looking to take on that walks program and extend it across the borough, because people like to be physically active in different ways. I hate the gym. I don't say that in our marketing campaigns, but I hate the gym. Yeah. And my point being is we need that broader strategic view, because we've got challenges resourcing the facilities, but then we've got all these other things that we want to do, and we are a part of the solution. And it's about having that longer term strategy.
I need to move us on, because I don't want this to be a conversation about physical activity. I don't want this just to be, because
we're presuming it's Tammy that's frozen, not me.
Yeah. Yes, I was wondering that for a minute. Is it me or Tammy? I think that what I'll do while Tammy comes back in is just because it was actually leading up to me saying a few words. And also there's some comments that Stephen has made in the chat which were setting up what I was about to say as well. So while I'm letting Tammy come back in, I'll just speak for a few minutes. And part of the context for this workshop and the series of workshops is that we are working with Stephen, with Neil Evans in the Healthcare Partnership to refresh the Healthcare Partnership strategy in a way that completely focuses on the altogether fairer Marmot approach. And that that's been an indication coming down from the very senior parts of the leadership in the Healthcare Partnership, saying that this is what we need to do over the next 5 years. And as well as the 8 themes of the Marmot approach, the ones that Tammy mentioned earlier, what we are looking for are 3 golden threads to go through the work. And they really do seem to respond to the things that we have just been discussing. The first one is about that, looking at how we invest money in a way that we are sure that it is supporting investment in the places that we need it most. Proportionate universalism, to give it its full proper title. And we're partly saying this, not because anybody doesn't know that, but because we're recognizing that if you don't actually put a focus on what is happening with investment, then you will end up with something that's the opposite of that proportionate universalism. You'll end up with something that supports people who need services less, actually getting greater access to them. So we need to actively focus, where are we allocating money? Are we allocating it in a way that best supports work on inequalities in health? Second golden thread is about focusing on poverty, recognizing that there is much already being done around poverty, that there are actions being taken by citizens advice bureaus, by community voluntary sector groups, by DWP about poverty and about accessing universal credit. What we're saying is that we think the integrated care system could actually add something to that. We could bring another focus to that work, which would help to give the work some support and perhaps move it on to another level as well. The third thing that we're looking to do is have a greater focus on equity in all policies, but not just policies, but about the way that we provide services, the way that policies are implemented as well. And in doing that, we're not just saying through the NHS and social care services, we're looking at equity in access to education, or wanting education to look at the way that people access their services, educational services, adult education as well, but also looking at what's equity in terms of access to transport, equity in terms of access to housing, because we know that those are the social determinants of health, that if we get equity in those areas, then we will start to have an impact on inequalities in health as well. And I'm going to quote John here, because I've quoted you, John, so many times, and you may not ever know it. But there was one meeting where you said that when we were talking about this work, that's great. That's what we need you to focus on. I don't need you to tell me what to do about cancer services, which is great because I don't know what to tell you about that. But you know what to do about cancer services. What we need to do is get the whole system focused on those social determinants of health, as well as having that focus, providing some kind of culture which supports Joe in the kind of work you're doing, talking to patients. Because that's inspirational work. We need to recognize that that stuff's happening, that Ian Senna's doing that great work as well. Give you a spotlight for that work, show the good practice, and provide that whole kind of cultural change. So that's what we're looking to do with the Healthcare Partnership Strategy. I'll offer Stephen if you want to say a few more words on that, but that's what I wanted to add to this discussion. And if you don't want to say anything more, Stephen, that's fine as well. We'll go back to Tammy.
No, I think you've articulated it very well, Alan. I have actually got the other slides open on the other screen, ticking it off as you were going along.
Good. Tammy, if you want to pick up again.
I guess I'm just sort of thinking, okay, so Alan's talked a little bit about this. I want to go back to some of the local people in local government here, because there's some sort of things you've just talked about in the NHS. I guess I just want to ask if this speaks to you, or what has just been said about the ICS speaks to you, because I guess, it isn't about adopting a single intervention or saying to, say, your public health people like Richard or Reforma, here's some money for a smoking cessation clinic this year. It's about saying, okay, let's try and look at these statistics and do something differently, and about approaching it over a couple of years. It's, Reforma just talked about, the reason why Halton's doing better is it's taken a couple of years over to really thinking about this as an issue. So I guess I'm looking at the councillors who are here and maybe Charlotte or whoever, just to talk a little bit about, does this make sense to you? So there's our Knowsley councillors, there's two of them.
I'll do it. Yeah. Okay. Oh, hello. Sorry, I have to keep moving away from the screen, but my computer completely gone and the IT service people were here, but I was listening. It's Chris Bannon, yeah, the Cabinet Member for Health. I think it all goes along with collaboration, doesn't it, really? I think it's about not sitting in our little silos and what we can do together. I think the things that from a Knowsley point of view, and I just think it's happening right across, is that our health and wellbeing board is really important, because we do get figures there, we do get actions from there, we do get challenged from there. So much as even the NHS saying, okay, well, we will make sure that we've got leaflets in our A&E department for people who are really suffering from deprivation to know where they're going to go. So I really do believe that, we can't do everything overnight. We should be working towards doing what we can whenever we can and doing everything we can. But I'm a great believer in communication and collaboration, because I think it's about us all coming together and saying we're doing this in the best interest of our communities. It will make our people more, from an NHS point of view, we can't make everybody healthy overnight, but going forward, we can put actions in that will help address that going forward, and what we can do, we can all help each other, I think.
I think it is about working together in partnerships differently, isn't it? It's about being able to challenge each other. And I think there's an issue here around accountability. I was having this conversation with somebody in the NHS this morning about how you can introduce all of these programs and then how do you know you've done anything? And she said to me, I feel like it doesn't amount to much. And she'd listed all of the things she was going to do. And I said, well, what do you actually mean? Because life expectancy, as we've said, takes a long time to change. But there are points, there are ways, you know, listen to what Joe, let me come back to you actually, or John, you can jump in. How do you know you're making a difference? Okay, you've actually just had some feedback, but I mean, honestly, because those cancer rates aren't going to go down in a year, are they? So how do you measure and hold yourself accountable and think, this is where I know change is happening?
So it is a challenge. And I heard the guy from Knowsley say, you're right, this is a generational shift, you know, and I think one of the challenges we have is that we are funded in short-term bursts and we expect to see changes. That I would go back to funders and say, are you willing to do this of a smaller amount over 10 years? Because it's a really, we consistently fund. I spent 30 years in the third sector. I was funded for 2 years at a time or for a year. Yeah. And by the end of that year, I had to write an evaluation project on something that was just beginning to breathe life. So I feel quite passionately about that side of it. I'm not skirting the issue. I'm saying to you that I think we need to say, what will Kensington and Liverpool look like in 10 years' time, not in a year? Not what will, for us, the political rotation of the NHS gives us the demands that we need to deliver in these in certain timescales. So when I talk and I do my training, I say to people, what will you do that will make a difference today, in 3 months, in a year, and beyond? Because actually, if we put a flyer, you know, it was a great example, put a flyer in front of a leaflet that says in easy read, if you can't read this leaflet, come in and ask. If we start asking people, 1 in 5 people in Merseyside can't read, but we don't talk about it. We don't use it as an upfront statistic. And if we start actually saying that and people start saying, oh, I can't read and I'm not embarrassed about it, we're making changes today, but we're making I'm not a politician. Okay. I know you're thinking I'm avoiding the question. I'm just going to push it a bit. We measure. So we measure everything. Every single person who comes out of our training sessions is expected to take something away with them and change it. After 3 months, we follow up with the organisation to see what changed, and we monitor that, and we push that if we can. If we're welcome back, we don't. Can I just ask? Sorry, let me go back to, I think, Stephen, and I can't remember, I'm going back to the other person with the Julie. But for those sort of people at that sort of director level, right, is that satisfactory, or are there some kind of metric? And I'm not saying a hard one, Joe, I'm not saying that at all. But is that enough for you to fund a program to say how many people they've trained? Or how can we try and get around this, that we're showing some, is there a need to show progress in order for something to get funded? I can, okay, I'll come to, who wants to go for that? Shall I go to John, or shall I go to Julie or Stephen? Okay, John, go for it.
I think if we can measure something, if we've got some decent metrics or some proxy metrics that we can evaluate, then fantastic, and we should always strive to do that. But I think we also need to have courage to try things and give it plenty of time to see if we can see a benefit. So, you know, some of the stuff we do in the Cancer Alliance, we do because we know that it's going to have a big hit. Targeted lung health check program, for example, we can see already in the data that people are surviving cancers that they would not have survived just a few years ago. So that's fantastic. There's other stuff we do that we know we won't be able to measure for a generation, but we've just got to have the courage to keep going. We can look at international research that shows that they, you know, other parts of the world did things 30 years ago, and now they're in a much better position than we are. That's good enough for me. You know, let's go for it. So I think there is something very much about courage.
I agree, courage and generational change. And some of these communities have been not treated well for many generations. So there's an element of trying to build trust in some of these places. Can I ask people just to go through really, really quickly? We've got 10 minutes left, and I also need to wrap up a bit. Claudia. No, yes, Julie and Charlotte, I'll come to you. Claudia.
Yeah, I was just going to mention something about logic models, which is an academic tool to help map exactly the intermediate outputs in a long-term process. So it's something maybe that maybe could be a topic for training or just sharing that.
Yeah.
Yeah, do you know about that, Tammy? Maybe. Yeah. I think.
Great. And the councillors, and then Charlotte, I'll come to you.
There you go. And just going back to some of my colleagues on the calls, and Clatterbridge, great respect. I worked on an oncology ward in all day, so I think if you know the service that you provide and the changes that have happened over the years, you know, are breathtaking and all for the right reasons. But if you look at sort of the big NHS hospitals now and the pressures they're under and whatever, to be able to do the work that we're asking around about directing and whatever, that's going to need an awful lot of this. Going to need an awful lot of funding. But one call out for anybody who's on the call who speaks to any council, you'll probably know that in Knowsley we launched the healthy food and drink advertisement policy, which we will be restricting. I was telling everybody on the television for the right reasons, because it, obviously our children, it's such a tempt to them, and we're hoping that the other authorities will join forces with us to make that happen. So just a shout out for that. But great respect for the NHS, and really think we should work together, but we really need to understand that they are so underfunded as well. Maybe they need to get some funding to employ somebody to derive a policy to take all this fantastic work into their departments to help give them support. Thank you.
Again, I would say that what's happened in Knowsley in terms of advertising is about a couple of people, one or two key people, including Esther, to really have a sense of moral duty, like we've seen. And I think it's about, it is taking a risk and being courageous. And I guess that's why we've brought you together as leaders, to ask you to think about your own personal capacity to address some of these issues using the power that you have. Charlotte and Julie, can I come back to you? Do you want to make a final point?
Yeah,
Charlotte?
I mean, a lot has already been said, and I support the points. I mean, some of it is about the things we do that don't cost. And I love Joe's bit, that is about making every contact count, educating people, kind of drip, constant. But funding is acutely challenged across the board, and we see the waves across the country. The local authorities in Cheshire and Mersey are in no different a position, and hard decisions will end up being made. But I guess we talk about, often it is that appetite and approach to risk, but how we view risk. So we look at what's the business case for change or investment. Well, what's the business case for staying as we are? There isn't a strong one, is there? And there's more risk in carrying on as we are than in some of the changes we need to make. So I think it's how we flip our attitude jointly to risk as well.
Sorry, what did say that again, Charlotte? You want the risk of staying as we are? Is that
so
what you said?
It's how we always try and quantify the risk of change or investment, or what's the business case for this tiny project, and what's the business case for staying as we are.
Oh, I like that.
It's the greater risk, isn't it, of just staying as we are.
Interesting. Yeah. Gosh, it's such a simple question to ask, but it's a really interesting thing. I'm going to come to all of you to ask you to go back on Mentimeter for just a second to ask about the change you're going to make. And Julie, I'll let you have one of the final. Yeah, it's a really nice thing, Charlotte. I like that. Julie.
Yes, I first put my hands up when you mentioned, I think John was speaking about outcomes, and I think we in the NHS do get really obsessed by measuring widgets and digits, don't we? And actually the reality is, but we should be measuring what difference is it making to people, what difference is it making to staff. And we've, within St Helens, we've been delivering a care communities programme, and part that is around holistic wraparound care for some of our most complex residents. That's wider. It's it goes into housing, it's social care, it will be education, as well as all your traditional NHS people. But actually, in terms of the time, doing all of this with no money, so like you say, there isn't money to do it, but what actually we have invested in, and all our staff have invested in, is the time to build the relationships, to come together, to actually say, right, okay, what we're going to do, what difference do we want to make for these people, and what outcomes do we want? And what we came up with in terms of outcomes were two very simple ones. Does this make a difference to our patients' lives, and does it make a difference to our staff lives? Because if you get it right, actually, you know, everything else, the widgets count themselves. But that's quite a different way of looking at things, and you know, people, you do want to know, and you want to be able to say, well, we've done this many multidisciplinary team meetings. So there's a bit of a balance of everything. But I think, as a lady said earlier, it is very difficult to put that amount of time into a project and know that it's not going to make a difference for 12 months, 18 months when we're funded a year at a time, and there's always that pressure. I mean, the reason we're able to do it in this is because we're not actually putting money into it, but in reality, if we get this right, all our staff's lives will be a little bit easier and our patients' lives will be a lot better. So I think all of these things we're talking about, it's time, isn't it? Time to do it well, time to but actually accepting the fact that this is not going to deliver. Not everything's going to deliver within 3 months, 6 months, or 9 months, and you've got to invest that time to keep going. Very difficult in a service that's only ever funded till next March.
Yeah, that's such a good point, Julie. And as I'm talking, if Louise, can you put up our final slide? But Julie, I guess I just want to pick up just a little bit of what you've said, because I think, you know, does it make a difference to people's lives? And what a brilliant question to ask yourself. But what I would also, and your staff, but what I would also say is, what would it, you know, is it making a difference to those people on lower incomes and your staff? Because sometimes when you look at the average, it's to really investigate that question with an equity lens. Because sometimes when you look at the average and you say, yeah, it has made a difference to people's lives, but really what we are saying in this is that's a good starting point. But the next question should be, and when I'm looking at the difference it's made in people's lives, has it reduced inequalities? Has it targeted those people on the lowest incomes who need those services the most? And so it's kind of it's a tweak to that original question, but it's just a lovely point to make, I think, Julie. I guess we wanted to just ask you as well. I mean, there's been a lot that's come out in terms of courage and inspiration and taking risks personally, and what some of the people we've seen examples of today of what has been achieved. And it's difficult, don't get me wrong. You can hit brick walls, certainly, but we wanted to ask you, what's the one thing that you'll do after attending today to take a little bit of that sort of accountability for yourself? Because sometimes that's the first place to start in terms of improving accountability for health inequalities, is to say, this is what I'll do. So again, if you want to use Mentimeter, you go to that menti.com and use the code 48407453. Be more Sinha. Oh my God, Ian would love that. Actually, I think he'd giggle a little bit. I'm going to take a photo and send it to him and let him know what we've been saying. But, you know, it would be nice if everyone could put one thing on here, because I think we can all, I mean, I always take something away from these training sessions about what I can do to my for myself as well, because sometimes it's, you know, this is tough work. You sometimes feel like no one's listening, or people just put up barriers. So it's been a nice session because it feels doable. I think you've all recognized that it is a bit difficult. But are there any other, as I'm sort of rambling on, are there any other closing points from our team or from the wider team about what you wanted to say, Alan or Hannah or Louise? Alan, you look like you're leaning forward.
Well, as ever with these conversations, I'm inspired by what people are doing. And I think I'm inspired to do more myself. And I want to take some of the comments that people have said and take that into that forum where I'm working with Stephen on the healthcare partnership strategy, because we really want that strategy to be useful to you. So some of the things I've been hearing here have given me inspiration to come back to that work and try to make it even better and more useful. Thanks, Tammy.
Okay, so, I mean, in terms of next steps, we're definitely, that's a really nice point, Alan, that Alan is listening and there's some other leads here, and we are carrying on. There's 3 more sessions that we're holding. So if you know any team members who would like to join, the people are still welcome to join and get in touch with Hannah and Louise, and they can let you know the dates. But I really want to thank you all for being honest, and I hope you don't mind that we've been honest with you and challenged you at points. And please stay in touch. I think we're interested to know, it is really interesting to know that there is already a lot going on, and sometimes we just need to communicate what we're doing a little bit better. So if there's good news to share, please keep sharing with us. And thank you all for your honesty and taking the time to join us today. Here's to addressing health inequalities and meeting each other maybe in a year's time and patting each other on the back for doing a great job. Thank you very much. And John, did you want to say something?
No, other than thank you. It's been good.
Okay, great. Okay, thanks very much all, and we'll be in touch and let you know how we get on. Enjoy the rest of your afternoon.